Ladies and gentlemen, it's a great pleasure to see you today and present you the data about the PBC Network research from EASL 2019. My name is Christian Trautwein and I'm working since 35 years on PBC. Actually, I started to dissect mitochondria, the outer and inner membrane, to understand where are the antibodies binding, and this was my start in this fascinating field. Today I want to present you the data from EASL. Thank you very much for attending this conference. I would like to tell you that I have selected, together with the Liver Foundation, 14 key pieces of research which were presented at EASL 2019, and they are 2 general things about PBC, 6 about the approved medicine and studies, and 6 others about non-approved medicine. So in summary, there are 14 key pieces which I will present today. First of all, the general discussion about 2 pieces which are relevant. Up to now in PBC, the PBC 40 score is well established. However, we have 40 questions, and therefore the idea was to improve this score. Therefore, there was a study on the PBC 10 score, a validated short symptom screening tool for PBC. And I think it's interesting to squeeze down these 40 questions. Therefore, the aim was to develop a less time-consuming tool than the PBC 40, which contains 40 questions to measure PBC-related quality of life in the clinic. And the method was analyzing large data set of PBC 40 responses and comparing them to only 10 questions, because this would lead to an improvement of this score. And the finding was that the new PBC 10 quality of life, consisting of 10 questions, was found to be accurate and represent the 6 quality of life aspect of PBC: fatigue, physiological, cognitive, physical, skin, eating or drinking domain, and was reliable. So this means that the PBC 10 could be a useful measure to track patients' progress during appointments and save clinicians time instead of the PBC 40 score. So one important aspect is when you have a patient, they want to ask, what is the reason why I have PBC? And therefore a new study which comes from the northeast of England in Northumbria goes into detail what might be environmental factors which are important to trigger PBC. And the aim of this study was to see if there are regional differences in the rate of PBC, but also PSC and autoimmune hepatitis, and if they are associated with a specific environmental factor in this specific region. So they compared the rates of PBC, PSC and autoimmune hepatitis across regions, and the finding was that the researchers found that with certain areas had a higher proportion of people with PBC due to specific environmental factors. And the results are shown in the following slide. And they showed that living in coal mining areas was identified as a possible trigger for PBC alongside genetic influences. And the findings were controversial, debated among specialists. No such pattern was seen for other autoimmune diseases like PSC and autoimmune hepatitis. And the conclusion is development of PBC is likely to be linked to environmental factors, but the mechanisms behind this and how to end with other factors is not known. So in the next part, I will summarize 6 abstracts about the approved medicine for PBC. And the first is the good performance of the biochemical response criteria after 3 months of OZO treatment in PBC patients. So originally we are looking after 1 year, and therefore it would be interesting to see if after 3 months already we can tell the patients that UDCA has a response. So the aim was to discover if patients that don't respond to UDCA well can be identified earlier than 1 year into treatment. So they did a comparison between patients' response to UDCA at 3 months and as originally done after 1 year or 12 months. And the results are quite interesting because basically there were 3 different groups. This means improvement after 3 months, no improvement after 3 months, and also no improvement after 3 months. But then after 12 months, then these patients still respond in the first group. The others did respond after between 3 and 12 months. and the last group is there's no improvement at all. So this means how do these three different groups are compared and what does it mean for the patients? So the finding was that a poor response to UDCA at 3 months was likely to persist after 12 months. So when you have already a result after 3 months, this will be maintained also after 12 months. However, a small number of patients did go on to respond after 12 months. So this means after 3 months they didn't respond, but after 12 months they improved. And these patients had an earlier disease stage and lower bilirubin levels. So this means that we have, in concluding, assessing symptoms at 3 months into treatment may be sensible approach to, as it means patients who do not respond to their current medication can be identified sooner. So this could be enable patients to find an effective treatment plan for then sooner. This means that if you look after 3 months and they don't respond, you can then switch to another treatment or add on a treatment, and this will be good for the patients. The second study is a preventive administration of USO after liver transplantations for primary biliary cholangitis, prevents disease recurrence and prolongs graft survival. So this means if you directly start after transplantations with USO, does it help to block progression of disease or reoccurrence of disease? We know that in 20% of the patients there's reoccurrence of PBC after transplantation. So the aim was to see if UDCA can prevent PBC recurrence following transplantation. So the finding was that taking UDCA following liver transplantations may lower PBC recurrence and prolong good liver function after follow-up in liver transplantation. And the findings were interesting because some factors were found to be associated with an increased likelihood of PBC recurrence, younger age at liver transplant, type of immunosuppressive therapy, and use of biopsy in the study versus non-invasive measures. And the conclusion is that despite only 20% of PBC liver transplant patients are at risk of PBC recurrence, the benefit of treating all patients with UDCA as a preventive strategy may outweigh the risk. So this indicates that using UDCA after transplantation is good for patients with PBC. The third study is the long-term assessment of the effects of obeticholic acid, OCA, in patients with primary biliary cholangitis on immune and inflammatory markers. It's a multi-site Canadian study, also with Europeans, and the background is that OCA is not only approved second-line treatment for PBC with no long-term follow-up. So this means we have only this second-line treatment at present, and we don't know the long-term effect. So in this study, the aim was to investigate the effect of long-term OCA use on liver function. The methods were that patients who had been taking UDCA for 12 months and did not respond well were given OCA or a placebo drug daily alongside UDCA. So this means we have now patients in combination and we want to know how the long-term effect is on liver function. So the results were after 36 and 48 months using the combination of OCA and UDCA treatment, and the biological signs of cell death and inflammations were reduced compared to those taking placebo. So this means also after long-term treatment, 3 to 4 years, there was a positive effect on addition of OCA, and this means overall taking OCA as well was found to improve liver condition and likely protects from further damage. However, these findings were based on blood markers. This means long-term evaluations of liver disease progression, ultrasound, elastography, biopsy are needed to support these findings. So this is the first hint that the long-term use of OCA is helpful in these patients. The fourth study is concerning the target PBC study, so changes in lipids. Characteristics in response to OCA in target PBC, a diverse, large United States real-world cohort. So the aim was, as you know, that PBC can affect lipid levels and lead to hyperlipidemia. However, PBC is not known to increase risk of heart disease. Therefore, it's interesting to have this aim to investigate how OCA affects lipid levels in PBC patients. And the method was to analyze data from medical records at 35 US sites. So the findings were as follows. OCA was found to improve lipid levels in PBC patients, reducing total cholesterol and the level of high-density lipoproteins, which was interesting. There was no effect on low-density lipoproteins, which is good. And this study contradicts therefore earlier work where it was found that OCA increased LDL. So this means, in conclusion, that OCA did not worsen hyperlipidemia in the real-life cohort, in contrast to the earlier POISE study, and therefore more data are needed to understand if and how OCA impacts lipid profile. I think this is a very interesting study because this indicates that maybe the cholesterol level are not impaired and maybe OCA is safer as originally thought. So side effects is an issue during OCA treatment, and therefore it's interesting that we have here a study which specifically looked on side effects during OCA treatment in a secondary care setting. So OCA is known to have side effects in some patients, such as itching or pruritus. At high OCA doses in earlier studies, many patients discontinued treatment early, most likely because of itching. In the POISE study, where patients took lower doses and were well managed, only 6% of patients dropped out. So the aim of this single study, UK study, was to investigate the experience of taking OCA in terms of side effects and discontinuation in a real-life setting. So the results were as following. In this real-life study, it was found that a third of the patients stopped OCA treatment due to side effects, and the most were pruritus. This is higher than the tested in previous research studies. However, AP levels were reduced, suggesting that OCA did improve liver function despite high rates of side effects and discontinuation. So this means OCA for some patients is likely to cause severe side effects, leading to discontinuations. Hence, alternative to second-line treatments are needed, and you know that they're on the way. Therefore, we can handle these patients in the future quite well. The sixth study is also out of the target PBC study, and it's a primary biliary cholangitis and autoimmune hepatitis. It's called overlap syndrome. Characteristics and response to obetiolic acid in target PBC, a diverse, large United States real-world cohort. So this means, what is a background in overlap syndrome concerning OCA? So in rare cases, patients have symptoms and features that fall under more than one disease, and these are referred as overlap syndromes. And the aim was to investigate the differences between PBC and autoimmune hepatitis overlap syndrome compared to patients with PBC only. So what is the difference between overlap and PBC? And the findings were quite interesting and promising because the study identified that patients with PBC and autoimmune hepatitis in the overlap syndrome group differ in characteristic to PBC only patients. Overlap patients have a more antinuclear and smooth muscle antibodies, higher rates of hepatitis, and more severe fibrosis. However, and this is important, OCA was similarly effective in both sets of patients, overlap and PBC, and all patients had similar rates of pruritus and fatigue, meaning side effects. In conclusion, also overlap patients differ from PBC patients. OCA seems appropriate for both conditions. A drawback here is that the lack of uniform definition of overlap syndrome. You know that the overlap syndrome definitions are not always the same, and therefore we have to better define the overlap syndrome. So in the last part of these presentations, I would like to go into medicines not approved for PBC. And the first study here is in patients with advanced liver disease, adding bezofibrate on top of UDCA does not prevent further progression of PBC. So I think it's a very important study. It's single center compared to the previous studies. However, you have to indicate that this is more advanced fibrosis. So the background is that bezofibrate is approved for hyperlipidemia, but currently not approved for PBC. There are data out for combination therapy for PBC patients not responding for UDCA alone. And bezofibrate and UDCA have been found to improve liver function and pruritus and possibly slow down disease progression in patients with early PBC. So the aim of this study was to investigate the effect of bezofibrate alongside with UDCA on PBC's progression in patients with advanced disease. Please keep in mind that in some countries, advanced disease with cirrhosis is still a drawback to use bezafibrate at all. So this means, in summary, the findings were that this study found that half of patients with bezafibrate as an add-on drug to UDCA improved liver function for a short period of time. However, it did not slow down progression or prevent complication in patients who already had advanced liver disease. So in conclusion, this study suggests that bezafibrate could be an effective add-on drug alongside UDCA in early stage of PBC. However, it seems not more efficient in advanced liver diseases, and therefore it's important to note that bezafibrate is a contraindication in patients with cirrhosis, limiting the amount of PBC patients who could take the drug, especially in advanced diseases. I think it's a very important message because there's some danger about that, because some patients may even be worse. So in the world of PBC right now, we have new drugs coming on the market, and therefore second-line therapy will improve in the future. And here's one study from Belgium, which is a first link in this direction, that maybe triple therapy even might be a possibility. And therefore this study looked on the synergistic effect of bezafibrate in PBC patients already receiving OCA and UDCA. So the background is that common PBC patients take add-on medicine if one alone is not effective. Bezafibrate could be one additional effect drug which might be interesting for these patients. And the study investigated whether bezafibrate improves the effectiveness of OCA and UDCA treatment on top in a triple therapy approach. And there were patients given the combination of OCA and UDCA for 4 to 5 years, and then bezafibrate was added on in this cohort of patients. It's a small cohort, however, it's an interesting cohort. And the findings were interesting because adding bezafibrate to OCA and UDCA decreases ALP in all patients. Some patients also had reduced itching and bilirubin levels, which is important because you know that OCA has already the side effect. And therefore the conclusion is that this small study shows that triple treatment of bezafibrate, OCA and UDCA may be efficient in patients who do not respond to a combination of two drugs. Of course, more data on safety and efficacy in large patient groups are needed. So we are now coming to a new drug, seladelpar, which of course is difficult to speak. However, it's a new drug compound, the PPR delta agonist, and the next abstracts and presentations will concentrate on this new drug. Seladelpar for the treatment of PBC, and in this case experience in cirrhotic patients. The background is that seladelpar might be a new treatment option for PBC. In this study, they investigated the new drug in combination with UDCA in patients with early cirrhosis. And the findings were a daily dose of 10 mg seladelpar has anti-inflammatory effects on the liver and improved overall liver function at 12 months by combining it with UDCA. Conclusions are that seladelpar at a dose of 10 mg may be safe and effective in PBC patients with early cirrhosis. However, earlier studies indicated that higher doses may be toxic for the liver. Additionally, cirrhosis affects liver metabolism. Therefore, patients with advanced cirrhosis may be more at risk of toxicity. Therefore, more research is needed to look at cirrhotic patients and to determine the correct effect of seladelpar dosing. As already indicated by the previous abstract, seladelpar might be different in metabolism in cirrhotic patients, and therefore this study now exactly addresses these questions: if cirrhotic patients have to be treated differently. And therefore it's important to know how the movement through the body is changed in patients with more advanced liver diseases. Therefore the study investigated the safety and tolerability of seladelpar and how it improves through the body, how it moves through the body in patients with advanced cirrhosis and hepatic impairment. Patients were given a single dose of 10 mg and the drug concentrations were measured. And now you see on the left side that obviously we have two different cohort of patients, those with mild liver disease and those with more advanced liver disease. And what you see is that when you have only mild cirrhosis, that the increase in dosing is 20%. However, in severe cirrhosis, it's 5-fold higher, 50% higher. So this indicates that the metabolism of the drug is dependent on the stage of cirrhosis. So the findings are, in cirrhotic patients with moderately or severe impaired liver function, the maximum concentrations of seladelpar after one dose is 5 times higher than healthy cohorts. So this means it's really risk. This suggests that dose adjustment and regular monitoring of the drug concentrations may be necessary in patients with advanced liver disease, and if seladelpar is approved for PBC, to ensure safety and prevent liver damage. The following study is the treatment of patients with PBC with seladelpar for 52 weeks, improve predicted transplant-free survival. So this was a statistical analysis to understand if the drug improves survival. So transplant-free survival is defined as survival without liver transplantations and free from liver-related death. The aim was to investigate the effect of seladelpar on predicted transplant-free survival rates as predicted by GLOBE score. Patients were enrolled on 2, 5 or 10 milligrams of the drug daily alongside with UDCA, again a combination therapy of the two drugs. The finding was that seladelpar has a positive effect on predicted rates of transplant-free survival. Note that this results is not yet based on actual outcomes of clinical changes, but is a statistical prediction and based on the GLOBE score, which uses different measurements of the blood. So in conclusion, seladelpar is effective for PBC and improved several blood markers. This raises hopes that this will also improve disease progression and transplant-free survival. Long-term clinical observations are needed to confirm this prediction. The next abstract now is again a new drug, which is called GKT-831, and it works on oxidative stress in the liver and it improves oxidative stress. And here in this first study of the drug, it's a phase 3 clinical trial, and it was looked at if this is effective in patients with PBC. So the background is that GKT-831 is a new drug being investigated for PBC. It is in a phase 2 study which looks at safety and effectiveness at different doses. And the aim was to evaluate effectiveness and safety of GKT-831 across sites in Europe. Patients who were previously unresponsive to UDCA were given 4 mg GKT-831 daily, twice or once per day, together with UDCA. The results are that GKT-831 can improve bile duct and overall liver function just 6 weeks after start of treatment. 4 mg GKT-8 twice daily also appeared more effective than a single dose. And in conclusion, GKT-831 may have the potential to be highly effective, but follow-up data are needed to see the effect of this new drug over long time periods. Also, the effect of GKT-831 on clinical measures, not just blood measures, needs to be evaluated, and researchers are planning to assess quality of life and liver fluorosis at 24 weeks into GKT-831 together with UDCA. In summary, I think we had very interesting sessions, and these 14 papers show us that the progress in PBC is ongoing. We have new drugs, we have new combination, and therefore I think the future to treat PBC patients is bright. Thank you very much. Oh, I just forgot. There are new EASL guidelines. And don't forget, EASL shows that PBC groups are very important. And therefore the interaction between the clinician and PBC groups improves the quality of the patients, improves therapy, and that is very important. Thank you very much.